like to welcome. I'd like to welcome everyone to Kofi Cash's final defense of his dissertation. Thank you so much. We've got a nice crowd in the room. Okay. In addition to our guests that are on Zoom, which I believe there's about 13, 14 also on Zoom. So 28. 28. Oh my God, Kofi. Okay, like in like the last couple of months.
Well, let's see if they stay on.
Are you paying them?
Anyway, we're very excited that you are here. Kofi has been working very, very hard on this dissertation over the last year and a half. So the way this afternoon will work, if this is your first rodeo, okay, as I'll tell you, is that Kofi will have the platform first, okay, and he will go through his presentation, which would be about approximately 30 minutes, okay. After he is done, then we will open it up for questions. The questions will first come from his committee members. Once we've exhausted our questions, we will then open it up to the floor, those that are in the room, those that are on Zoom. For those that are on Zoom, you can put it into the chat area and Shirley can read out your questions to us, or you can just unmute yourself and ask the question. Then once everybody has had an opportunity to ask questions of you, then the committee will go into its executive session. And when we go into the executive session, we will have everyone, including Kofi, leave the room in addition to closing out the Zoom at that point. Just so you understand what we do is his presentation will be recorded. The Q&A section will be also recorded, and then we will stop the recording while everyone is out of the room and we're in executive session. And then when Kofi comes back, because no one ever gets out of a dissertation without making revisions, okay? That except for me. I mean, Bob too.
And it doesn't count.
Just so again, I'm writing notes, he's writing notes. We just want to make sure we capture everything. So that's why we do the recording. So with that said, let's turn it over to Kofi. I know he's very anxious to share his work with us.
Thank you, Dr. Borkowski. Good afternoon. I'm very excited to share this work with you today. The doctoral process, this particular doctoral process has been transformational for me, both personally and professionally. I intend to provide an overview of my dissertation manuscript and reveal some surprising and original results from my study. But before I do, let me recognize family, friends, and colleagues who have taken the time today to attend this event in person in the classroom here, as well as through the virtual platform. Everyone has busy calendars, and I'm very grateful for folks taking the time today to be here, both in person and through Zoom this afternoon. Thank you for that. I want to take the time to acknowledge the members of my dissertation committee. This study was directed by Dr. Nancy Borkowski. Drs. Lamech, Meese, O'Connor, and Weech Maldonado also served on this dissertation committee. These scholars provided on a regular basis guidance, constructive feedback, and support throughout the journey. Collectively, this dissertation committee improved the quality of the study. I'm grateful to each of them for having served. The formal name, the title of my dissertation today is, Does CEO Education Matter? The relationship between doctoral educated hospital CEOs and organizational performance. These are the topics that will comprise my presentation overview this afternoon. I want to be sure that I share with you how I developed the literature, the conceptual framework, the study's hypotheses, and the selection of methods. I also want to take the appropriate time today to share with you the study's limitations and implications for the U.S. health services sector. I will conclude with some surprising and original results, as well as a call to action for this audience today. JFK said, "Leadership and learning are indispensable to each other." This quote resonates deeply with me. It encapsulates the motivation, a motivation for me conducting this study. A second motivation came about from my colleagues in practice. Many of my colleagues were dubious about this doctoral level pursuit. My colleagues would ask me over the last several years, why would you want to pursue this doctoral education, this doctoral degree after 22 years of practitionership? Why would you want to pursue this doctorate degree when it is not a requisite for a hospital CEO appointment? That provided motivation within me to seek a better understanding. Is there a relationship between doctoral educated hospital CEOs and organizational performance? The third motivation really comes from a desire to understand, is the pursuit, is the completion or attainment of doctoral education, can that translate beyond the unit of the individual? Is there a potential for doctoral education to impact not just the micro, but the macro, and that is organizational performance? These considerations really encapsulate the motivations that I had toward conducting this study. This graph and table illustrate the problem statement very well. The hospital CEO role is under siege. Hospital CEOs are under tremendous
And
pressure.
at home too? Oh, no. Oh, you just, okay.
Hospital CEOs are under tremendous pressure. Performance expectations regarding employee engagement, financial stewardship, patient experience, patient safety, clinical quality have never been higher. Yet the healthcare industry has the greatest percentage of doctoral educated CEOs than any other industry in America, as this data behind me says, just over 15%. But yet, the healthcare industry has the least amount of studies examining the relationship between doctoral educated CEOs and organizational performance. This problem is concerning because of the costs associated with poorly chosen and ineffective hospital CEOs. This problem statement screamed at me throughout my engagement and reading of the literature. The research question. I wrestled with this research question for weeks. At the start, as you may imagine, I had many questions that I wanted answered. My curiosity ran over with the thought that I knew and understood that many research questions were applicable, appropriate, and sound for this research study. However, I learned very quickly through my engagement with Dr. Borkowski that was not going to cut it. And so I landed on this one. And I'm very proud of this research question. This research question provided discipline for my work, my research through the literature review and writing the manuscript. This research question has the right, I believe, characteristics for a sound question. And that is, the characteristics of a research question are focused, arguable, researchable, and most important, answerable. I believe these characteristics exist with this research question. We transition into the literature review. The literature review, arguably, from my perspective, is the most important chapter in my dissertation manuscript. I constructed a literature review that was chronological and comprehensive, which spanned over 80 years. This literature review covered the most germane research streams surrounding the research topic. The first research stream I delved into centered around the theoretical framework, UET, or upper echelons theory. This theory was introduced by Hamrick and Mason in 1984. Upper echelons theory posits that the backgrounds and education of upper echelon leaders influence the strategic decision-making processes of complex organizations, which then leads to varying organizational performance. UET has been well validated empirically and has been well anchored in the literature for the past 40 years. UET, upper echelons theory, is my selected theoretical framework for this study. Moving to another important research stream was under strategic leadership. Strategic leadership was well defined in '96 by Finkelstein and Hamrick. Strategic leadership or strategic management centers and focuses on studying upper echelon individuals and groups such as CEOs, TMTs or total management teams, and boards of directors. Because there was such a paucity of studies in the healthcare sector examining doctoral educated CEOs and organizational performance, I had to extend the literature review out beyond the healthcare sector and into other industries and new and emerging economies. A few of those are listed here for your convenience. The extension into new industries and new and emerging economies was very helpful to strengthening the literature review and forming and defining the literature gap. The literature gap that yielded from the literature review had a couple characteristics that I think holds very important and holds toward my decision making for this study. First off, most of the doctoral educated hospital CEO literature focused on physician administrators, only physician administrators, and excluded those doctorates that were research-based, a jury-written dissertation or a doctoral level capstone project. Most of prior publications only included a hospital CEO tenure of 3 years or less, 3 years or less. And the study samples that were used in prior literature was not as geographical diverse, meaning they only had 1, 2, or 3 perhaps states represented in their study population. This came and started to narrow in on the literature gap. I wanted to present these authors very quickly because the literature review did not, I repeat, it did not reveal a consensus of significant and positive results. It did not. These authors are important. This collective scholarship is important because they examined the same research topic and they came away with inconsistent and mixed findings. The reason why this is important because it further accentuated and defined the literature gap. These scholars, these publications were important to my dissertation. They comprise the spine, the spine of the literature review. These publications, you will notice, are not 10, 20, 30 years old, but within the last 6 years. I think that was very important and was a strength to my overall study. But I wanted to reveal these collective works so that you would understand how I made decisions within my study and the fact that my decisions were grounded and anchored in prior works. For example, Galstian et al. 2018, they were one of the very few studies that combined professional and research-based doctorate to define their independent variable of doctoral educated hospital CEOs. One of the very few. Daurici 2021 gave insight into the importance of longer tenure, especially between 4 and 9 years. That was the sweet spot they came up and found from their meta-analyses regarding CEO tenure. So my study included longer. My study included a tenure of 4 years. My dependent variables that I chose came from TASI, C, and Bellicin. 2019, 2022, and 2023. These dependent variables were very important and are widely accepted within the literature, especially within the hospital healthcare space. I selected my dependent variables largely on these studies. Crescentio 2021 was instrumental because they were the first systematic review dealing with the health services sector and CEO doctoral education, healthcare related. That review was very important because they found that the CEO's doctoral level education did have impact with organizational performance. And lastly, Ergart and Zane, 2022. This was a powerful study for 2 reasons. One, they only looked at hospital CEOs who had PhDs, period. For the first time, you'll see here, for the first time, a study not looking at the physician, but looking at the research-based educated CEO. And here, their findings was important because they found financial, positive, and significant results with respect to the relationship. These collection of works, published works, anchored and grounded my decision-making as I moved through the study. They say a picture is worth 1,000 words. This is my conceptual framework. This conceptual framework was developed after I conducted the literature review. As you can see on the left, my left, upper echelons theory is the lens through which I examine the phenomena. Completed doctoral education, the independent variable, is an observable characteristic for hospital CEOs. According to UET, it is theorized that that independent variable, completed doctoral education, will influence in a major way, organizational strategic decision-making, which then leads to varying organizational performance. This conceptual framework, I feel, illustrates and encapsulates my study in one figure, one illustration. The hypotheses were developed from the review of literature. I had 2 primary hypotheses and 3 sub-hypotheses pertaining specifically to quality, patient experience, and patient safety. When formulating these hypotheses, I wanted to adhere to parallel construction, and I wanted to make sure that these hypotheses were testable, answerable. So I'm going to read one from the screen, the top first hypothesis, so that you understand my notion, idea around parallel construction. Hospitals led by CEOs with doctoral degrees will report higher operating margins than hospitals led by CEOs without doctoral degrees. That language and that construction was consistent throughout my hypotheses, which I felt was important with respect to being answerable and testable. We're going to transition to the study design and methods of the study. My study is a quantitative, non-experimental study design. Cross-sectional period was 2019. So again, for clarity, a cross-sectional, quantitative cross-sectional, quantitative, non-experimental study design. It consisted of 509 hospitals. What I wanted to bring forward is the tan states represented here on the map are the represented states within the study population. You'll see that my study population consists of the three major states, California, Texas, and Florida. But it omits New York. It omits New York because in that particular geographical division, defined by the US Census Bureau, in 2019, New York didn't have more hospitals than Pennsylvania. Pennsylvania had more, and therefore Pennsylvania, according to my method, was selected and not New York. Another item I want to just reinforce is that every hospital CEO in my study, 509 of them, had a tenure of 4 years. Again, this differentiated from prior publication. And I developed that 4-year proxy by looking at 2016 and 2019 data. Because this was a quantitative study, I used secondary data sources. I also manually entered leapfrog grades as well as the CEO education data. But keep in mind, even though I manually entered them into my analytical data set, they ultimately came from secondary data sources. My variables, I had 4 dependent variables that defined organizational performance. 4 of them. 1 was continuous operating margin. The other 3 were dichotomous variables, CMS star ratings, HCAP star ratings, and leapfrog safety grades. I had a dozen control variables, 8 of which were organizational-based control variables. And here I just want to emphasize one more time that my independent variable was inclusive of both professional doctorates and research-based doctorates. Again, leading the way was Galstein in 2018. Because of the variables selected, I used 3 fundamental statistical models in running my analyses. I used bivariate regression, I used ordinary least squares, multivariate linear regression, and I used ordinal logistic regression for my statistical models. Once I completed the analytical data set in Excel, I migrated that analytical data set into Stata 18 to perform my statistical models. Okay, let's get to the fun stuff. This is the results. Let's jump right in, shall we? So for the first hypotheses, it dealt with operating margin, hospital operating margin. I found that there was a statistically significant relationship between CEO doctoral education, hospital CEO doctoral education, and hospital operating margin. However, the data ran counter. The data was negative in the wrong direction, and therefore was counter to my study's hypothesis. This was highly surprising, as you can imagine. On average, hospitals being led by a doctoral educated CEO had a 0.4% lower operating margin than those hospitals led by a CEO without a doctoral degree. Hypothesis 1 was not supported. Leapfrog grades. I found that there was a statistical significant relationship with CEO doctoral education and leapfrog grades. In fact, for those hospitals earning an A or B leapfrog score, there was an 87% higher odds that those hospitals were led by a doctoral educated CEO. Hypothesis 2C was supported. CMS star ratings and HCAP star ratings, neither of them proved to have a statistically significant relationship. This slide has depth and weight. I'm going to park here just for a moment. The strengths of my study. I believe the strengths of my study was the study design, the tenure greater than 3 years. I believe that the geographical diversity of the study population was strong. And it helped with making incremental pathway forward to generalizability. I believe those were some of the highlights of my strengths. I believe that the literature review, the comprehensive chronological literature review, baked in with Hambrick's consultation also was a major strength. Limitations to my study. Limitations to my study were as follows. I excluded rural hospitals. I made that decision. I excluded rural hospitals, 50 beds or less. Because this was a cross-sectional study, I was unable to look at performance of hospitals over time. We all know that there's a difference between relative performance and absolute performance. Cross-sectional study will very rarely show any insight into that. The third limitation to my study dealt with education. From the literature, I understand that there are three components to education. You have attainment, you have quality, and you have achievement. My study is only looking at attainment of completed doctoral education. Quality of and achievement of are not part of this study. Future research. I have many, but for this segment of the presentation, I'll keep it concise. One is I do believe that beyond upper echelons theory, there are other theoretical validated frameworks that could have been chosen to study this phenomenon, such as human capital theory, transformational leadership theory, complexity theory, and expert leadership theory. All are validated empirically and could lend fruit here, examining the relationship. Implications. From a practice standpoint within the health services sector, I think my study suggests that there is perhaps a need to look at the financial management rigor, the financial management competency and qualification with respect to doctoral educated hospital CEOs. This statistical finding that I found was both present in the multivariate linear regression, but it also was present when I broke out in my post hoc analysis MDs versus PhDs. And it was statistically significant that professional doctorates still had a lower operating margin. So there is something to pause and to look at in practice for current and prospective hospital CEOs. From a research perspective, there's an opportunity, I think, in the academy to, based on my study's findings, to ensure that the preparation of doctoral students in the health services sector are sound with respect to these dependent variables. It may be an opportunity to see whether or not the preparation, the curricula, the training, the case studies used to ensure that when these doctoral students, executive doctoral students, go out into the practice, that there is enough optimization of value once they leave and graduate. Pardon me. From a policy perspective, I believe that the American Hospital Association and the ACHE, based on the findings of my study, there may be an opportunity, I would like to see it personally, where we would have a hospital CEO education attainment database. There is not a database that maintains accurate information regarding hospital CEO education. I believe that that would be helpful for many involved, stakeholders involved. And lastly, from a policy perspective, I believe based on the findings of my study, it may be advantageous to draft policy in prescribing the importance of hospital CEO continuously learning regarding the various outcome needs and pressures that are in the marketplace, such as hospital operating margin, patient safety indicators, clinical quality assessment, and patient experience. These are the limitations, these are the implications I believe that my study offers moving forward. In conclusion, I just have a few items that I would like to cover and synthesize. First, I want to answer the research question. That's important. And again, the research question was designed to be answered. The way I answer the research question is this. My study does not yield results where I can simply say yes or no. There's a relationship, there's not a relationship. I don't think that that would be appropriate or right. The way I answer the research question is this, based on my study's results. There is a relationship that I found between doctoral educated hospital CEOs and leapfrog scores, leapfrog rates. That was a positive relationship that I found quantitatively to exist, significantly and positively. I did find a relationship between doctoral educated hospital CEOs and operating margin. Although significant, it was counter. It was a negative relationship. So I found two quantitative relationships with very selected dependent variables. Again, hospital operating margin and leapfrog rates. The SOC. The SOC stands for Significant Original Contribution to Knowledge. I argue respectfully that this study offers a significant original contribution to knowledge for two reasons. One, this study addresses the literature gap squarely. This study advances some of the study designs from prior publications. And second, the results that I found, I believe, were both surprising with the operating margin and original with the leapfrog grades. From my understanding, from my review of literature, there has not been any prior publication that has studied doctoral educated hospital CEOs and found a positive and significant relationship to leapfrog grades. Does hospital CEO education matter? That's really a global question facing strategic leadership scholars. And I think I would be remiss if I didn't just touch upon that. From my study, based on my findings, my study cannot support unequivocally a statement that says hospital CEO education matters. Because that question is really baked into a positive connotation. So, like many things, additional research is needed. Additional research is needed in this space in order to see if doctoral education can predict outcomes that matter, not to just simply the hospital, but matter to patients, matter to clinicians, matter to employees, and most importantly, to the local communities. My study cannot answer this question in full at this time. I leave you with a call to action for this particular audience. I encourage you, I implore you to engage and contribute to the ongoing discourse and research about whether or not doctoral education is a requisite for a hospital CEO appointment. Hospital CEOs are upper echelon leaders. Our hospitals are complex organizations. If we subscribe to upper echelons theory, just maybe, perhaps, higher levels of hospital organizational performance may require higher levels of education in the form of a doctorate degree. I thank you for your attention and your support. I yield the floor back to Dr. Borkowski.
Okay, thank you for that very, very informative presentation. Okay, So what we're going to do, as I had mentioned before, we're gonna first open it up for questions from your committee. And then we'll go to the floor, okay? So, Dr. O'Connor is to my immediate right, so would you like to start us off with your question?
Sure. There's one thing, you found that significant relationship in the right direction with the leapfrog outcomes. And I guess with leapfrog, it's they look at structural measures, process measures, patient safety related organizational culture elements in there. So leapfrog, okay, there's this idea that there's leapfrog, and you said that it enables managerial discretion of the CEO. And I guess therefore there was a larger kind of like doctoral CEO effect on leapfrog. So how does the doctoral CEO amplify this